Okay, so in this lecture we talked about inflammation, we talked about acute inflammation and chronic inflammation, and we started by basically just reviewing how our body kind of protects itself. So really there are three lines of defense. The first line is just our innate barriers like skin and mucous membranes and the secretions of mucous membranes, things that you're born with. Now, the second line, this is the inflammatory response, which is mostly what we talked about and we'll talk about in more detail. The third line, this is when the immune system really gets involved. Now, there is obviously immune system activation in the second line, so the second and third line are kind of connected. So let me kind of just went through this. The first line, these are just physical barriers. The second line is the inflammatory response, kind of the innate immune response. And then the third line, this is kind of furthering the immune response, and so on. So acute inflammation, this is when tissues are injured. Okay, and there are lots of ways that tissues can be injured, through, physical trauma or infection or burns, lots of ways that tissues can be damaged. So the whole job of inflammation, especially acute inflammation, is to increase blood flow, and what that does is that's going to bring good things to the site. Okay, so increase blood flow, bring good things to the site, and then eventually heal the tissue. Now, the vascular response, this is kind of the first thing that happens in acute inflammation. So you have the injury, the blood vessels are going to become leaky, they're going to vasodilate. Okay, and what that does, that increases blood flow, and this allows things like clotting factors and immune cells and a bunch of other things to come to the injured site. Now, ACUTE, this is that, very high protein. There are some white blood cells in it as well, and, this is a major sign of the vascular response, and this is going to contribute to the edema, which we know is a cardinal sign of inflammation. So again, this is just kind of showing, in a normal state, not much is going on, everything's fine. But here we can see that the blood vessels get leaky and white blood vessels start to come to the site through these dilated vessels, and there's going to be a lot of other things going on, which we'll talk about. So inflammatory mediators, things that cause inflammation. So we have inflammatory mediators within cells themselves as well as in blood plasma. Okay. So mast cells and basophils, these are found in the connective tissues. Okay, they're just kind of hanging out in the connective tissues. They're waiting for, something to respond to. So when there's injury, what they're going to do is they're going to do what's known as degranulate. And what degranulate means is basically these cells, so for example, here is a mast cell, and this mast cell has these little granules. All right, and when there's injury to tissues, what they do is they release the contents of these granules. Okay, basophils pretty much do the same thing. Okay, so that's what degranulation is. Okay, they're releasing the contents of their granules. And these granules have things like heparin. So heparin is going to thin the blood. That's going to help, these components of blood get to the injured site. Serotonin, histamine, leukotrienes, prostaglandins. All of these, one way or another, are known as vasoactive factors. Okay, they act on the blood vessels or the blood in some way. So other immune cells are going to come to the site. So really the first ones are going to be neutrophils because they're so abundant, but also lymphocytes and monocytes will come to the site. And we'll talk more about monocytes and macrophages with chronic inflammation, but they do make their way to the site even in acute inflammation. So platelets are floating around, and they're going to obviously promote clotting. They're also going to attract white blood cells to the site and eventually participate in the healing of the injured tissue. Now, some of these plasma mediators complement proteins. So remember, complement's job is to basically either kill pathogens directly or flag pathogens for destruction. That's called opsonization. But they also enhance the inflammatory response. Okay. Other plasma mediators, clotting factors, and then the kinins. So As far as the kinins, I basically told you to remember bradykinin, okay? And I want you to associate this with pain. So bradykinin is going to stimulate nerve endings for pain, all right? So the complement system, again, its job is to form the membrane attack complex, which is going to kill pathogens directly. It also is going to enhance the inflammatory response, but it's also going to cause opsonization, which will enhance phagocytosis. In the clotting system, there are two pathways. We didn't talk about this in detail, but these are just some of those plasma mediators that are involved in the acute inflammatory response. Okay, so the cellular response. So we've dilated these blood vessels. They're nice and leaky, thanks to histamine and heparin and things like that. Now immune cells can come to the site. And really the first ones on the scene will be the neutrophils because they're so abundant in blood, but also monocytes a little bit later. And they're going to travel to the site by chemotaxis. So, we just talked about, how complement enhances the inflammatory response. Well, it's some of these molecules that basically attract these cells to the site. That's called chemotaxis. Okay, so they're moving towards a chemical stimulus. Once they get there, they're going to adhere to the endothelium, which is the lining of the blood vessel, and that's called margination. Once they marginate, they are going to exit the blood. They're going to leave the blood. They're going to travel through the endothelial layer, and that's called diapedesis. Okay, so that's what's happening here. So we have these neutrophils. They're just kind of rolling along. So this is the chemotaxis portion, and then they're going to adhere to the endothelium. Okay, so this is called cellular adherence or margination. And then once they adhere, they're going to exit the blood. They're going to travel through this endothelium, okay? And this is diapedesis. So the cardinal signs of inflammation, so redness, heat, swelling, pain, and then loss of function. So redness, again, that's from the vasodilation. Heat, that's also from the vasodilation, so blood is closer to the skin. Swelling, that's the exudate that's flowing from the leaky blood vessels. Pain, because we have things like kinin systems that stimulate nerve endings, among other things, and of course loss of function. So general manifestations of inflammation. So fever. Fever is a systemic manifestation of inflammation. Okay, and basically we have inflammatory chemicals, things like interleukin-1, and a couple others. You don't need to worry about that. But basically, these inflammatory chemicals are going to trigger the hypothalamus to, cause the blood vessels to constrict, cause the muscles to shake and shiver, to increase body heat. Okay. Lymphadenitis. This is enlargement or inflammation of the lymph nodes. Again, you see this with infection, but you also see it sometimes with cancer. Some findings of blood tests. So you might find elevated number of white blood cells. That's called leukocytosis, and that occurs often in response to bacterial infections. Now, leukopenia, which I mentioned in class, I want you to associate that more with viral infections. Now, that's not always the rule, but that happens. Elevated C-reactive protein, so this is an acute phase protein that you see in inflammation. Increased ESR, erythrocyte sedimentation rate. So this is basically these inflammatory markers can kind of attach themselves to red blood cells, and when they do that, they become heavier. So you expect and you will see increased ESRs in inflammation. And there's lots of other things too, and we'll talk about those with the specific diseases. So chronic inflammation, this is persistent inflammation that lasts several weeks or longer. Like I said in class, typically when we talk about chronic inflammation, it's more than 6 months, and in the case of autoimmune diseases, lifelong. So it could be due to chronic infection, for example, like tuberculosis, a continuing injury, like if you keep spraining your ankle, it's never going to get better, or autoimmunity. So all of the autoimmune diseases really are diseases of chronic, lifelong inflammation. Now, in chronic inflammation, we see more monocytes and macrophages. Remember, monocytes become macrophages once they leave the blood and get into the tissues, but also lymphocytes. So in the acute response, that was mostly neutrophils and some monocytes. But here we see more monocytes, macrophages, lymphocytes. Another type of cell that we see is fibroblasts. Okay, and fibroblasts produce fibers. Okay, and those fibers will basically make scar tissue. And scarring is kind of a hallmark of chronic inflammation, and something you should associate with chronic inflammation. Another thing that's associated with chronic inflammation is a granuloma. A granuloma is pretty much just a bundle of macrophages, also lymphocytes, that are trying to trap something that, is bad, that they think is bad. And a lot of times it is. So, for example, in tuberculosis, you'll get these granulomas that form, and sometimes you get a bunch of them, and it will form what's known as a Goens complex. We'll talk about that next week. But basically, they're kind of trapping the Mycobacterium tuberculosis. But you see them in other diseases too, like autoimmune diseases. So general manifestations of chronic inflammation. So you have some of the similar manifestations as acute inflammation. However, you see things like malaise and fatigue, fever, anemia, nausea, weight loss, a lot of non-specific symptoms. And you'll see those a lot with the autoimmune diseases. Another hallmark of chronic inflammation, especially autoimmunity, are periods of flares and remission. So flares, these are periods where symptoms are worse. And remission, these are periods where symptoms are better. Now, the treatment of chronic inflammation depends on the cause. Unfortunately, when it comes to autoimmunity, we don't really know the cause completely, but we'll talk about that. Okay, so the first disease we talked about was rheumatoid arthritis, and this is an autoimmune disease. And like I said, you should really, even though we associate rheumatoid arthritis with the joints, we should really associate all autoimmune diseases as systemic diseases, okay, because they really have systemic manifestations. But basically, this is a problem of the synovial joints, specifically the synovial membranes, okay? Age of onset, typically 36 to 50 years, and like the majority of autoimmune diseases, it affects more females than males. Now, the pathophysiology. The first thing is you have these antigen and autoantibody complexes. Autoantibody is an antibody that is specific for our own tissues, and that's bad. And basically they form, and they kind of deposit themselves in the synovial membranes. Now remember the synovial joints, so if this is our one bone, and this is the other one, these synovial membranes, are kind of like this. They're the ones that secrete synovial fluid. Okay, so this is really kind of the focus of the problem. But anyway, when these complexes kind of deposit themselves in the synovial membranes, it induces an inflammatory response. You have immune cells come in, you'll have fibroblasts come in, and basically you will lay down scar tissue. The synovial cells, the cells that produce synovial fluid, will undergo hyperplasia. So just your kind of like a typical immune response or inflammatory response. Okay. The problem is, even though a lot of these people have flares and remissions, each time you have a flare, it just kind of continually damages that synovial membrane. And what can happen is it becomes so scarred that you lose movement at that joint. Okay. And that's called ankylosis. So another hallmark of rheumatoid arthritis is what's known as the pannus, and this is granulation tissue that is going to kind of form over the synovial membrane and also some of the cartilage of the joint. So it really becomes, the problem moves from the synovial membrane to the cartilage, lining the ends of the bones also. And you can see down here kind of the inflammatory response that's occurring. You have fibroblasts coming in, they're making scar tissue. You have macrophages coming in, lymphocytes, just a number of things. So clinical manifestations, severity depends, case-to-case basis. That's going to be true for pretty much all the autoimmune diseases. There's going to be a spectrum of manifestations, okay? And, it can affect any of the joints. It typically does so symmetrically, so if you have one hand affected, typically the other one is also. But some other manifestations, you have systemic manifestations like fever, weight loss, fatigue, malaise, but also erythema at the joints, decreased range of motion, sometimes to the point of ankylosis, pain, and some others. So as far as diagnosis, history exam, rheumatoid factor, this is just measuring autoantibodies. It's not specific for rheumatoid arthritis. Also an elevated ESR. Again, that's not specific for anything either. And then testing of the synovial fluid, which would kind of indicate some of these inflammatory cells and things like that. And also imaging of the joints themselves. So treatments, immunosuppressants, the biologic medications like Humira, sometimes joint replacement, just general anti-inflammatories, and then ice and heat can be really helpful for pain and discomfort. So here we see typical manifestation of rheumatoid arthritis. Sometimes you get these subcutaneous nodules also. You'll see these pretty often. Okay, then we talked about chronic gastritis, which is caused by either an autoimmune response or most commonly by infection. So in infectious cases, basically, it's an infection with Helicobacter pylori, H. pylori. And what H. pylori does is it kind of breaks down the mucosal lining which protects the stomach. And what that does is that kind of exposes the submucosa to the acidic contents of the stomach. And that can be very damaging. So you also have neutrophils which migrate into an area known as the lamina propria. So lamina propria is just a connective tissue that underlines mucous membranes. And you find a lot of immune cells and things in there. But they're going to come in and they're going to try to phagocytose the bacteria, but they're not going to be successful. They're not going to be able to take care of the entire problem. H. pylori is a really, really tricky and very creative bacteria. And as far as the autoimmune types of chronic gastritis, typically due to autoantibodies against parietal cells. So parietal cells, these are cells in the stomach, and they secrete things like hydrochloric acid. They also secrete intrinsic factor. So that can be a problem for sure. So as far as infectious cases, they will have dyspepsia, discomfort in the epigastric region, heartburn, nausea, very common. Sometimes relatively asymptomatic. But if they are symptomatic, they will typically have these things. Now the autoimmune ones also can be asymptomatic, but also present like an infectious type of chronic gastritis. The thing here, though, is that oftentimes the first sign of autoimmune chronic gastritis is pernicious anemia. And pernicious anemia is due to a lack of intrinsic factor. So you need intrinsic factor to absorb vitamin B12. And if you don't have intrinsic factor, which is the case here because parietal cells are being destroyed, you will have pernicious anemia. So diagnosis, endoscopy, so an upper endoscopy, they'll do a biopsy, possibly a breath test, which we talked about in class. And then treatment, if it's an infection, antibiotic treatment. And as far as the autoimmune cases, B12 injections, because again, they're not producing intrinsic factor. Also, anti-inflammatory medications. Okay, so this is just showing the, severely reddened mucosa. I'm not sure if this is autoimmune or the infectious type, but this is characteristic of chronic gastritis. So pancreatitis, inflammation of the pancreas, this can be acute or chronic. So acute pancreatitis, this is when you damage exocrine portions of the pancreas. So these are the portions that produce digestive enzymes. Most commonly due to abuse of alcohol or a gallstone that gets lodged, which I'll show you. And what happens is when you have these digestive enzymes, that are kind of leaking out of these damaged portions, they can activate earlier than they should. And this causes what's known as autodigestion. So the pancreas can kind of autodigest itself, and that's really bad, and it can be deadly. Now, chronic pancreatitis, this is typically associated with chronic alcohol abuse. But there are also autoimmune types of chronic pancreatitis. With the chronic types, typically not only the exocrine portions of the pancreas are affected, but also the endocrine portions. So the portions that produce insulin, glucagon, and somatostatin. So clinical manifestations, epigastric pain that may wax and wane, vomiting, diarrhea. Definitely see elevated amylase and lipase with the acute types, and some other things. So the chronic types, again, epigastric pain, umbilical pain, sometimes right hypochondriac pain, diarrhea, weight loss. Somewhat similar to the acute types, but sometimes you don't see all of the things that you see with acute. Acute, these people are very, very sick. Chronic takes more time to develop. Diagnosis, symptoms, blood work, so amylase and lipase are huge, as well as liver function tests and imaging to look at the pancreas. So treatment, it's based on the type of pancreatitis as well as the severity. So, lifestyle and behavior modification might be sufficient for, milder cases of chronic pancreatitis, but, fluid correction and surgery might be necessary for other types. So this is a common cause of acute pancreatitis. So basically here we have the bile duct. So the bile duct joins the main pancreatic duct, which goes back here. And if you get gallstones right here, what happens is this blocks off the ability for this main pancreatic duct to carry those exocrine secretions, so those digestive enzymes from the pancreas into the duodenum. So basically this can start to auto-digest itself. And like I said, that can be deadly. Not a good situation at all. Okay, then we talked about inflammatory bowel disease. So inflammatory bowel disease has two main categories. You have Crohn's disease and ulcerative colitis. And we're going to talk about each individually, and you should definitely be familiar with the differences between the two. So Crohn's disease, the big thing here is this can affect any part of the GI tract, so from the mouth to the anus. Most common sites, though, are the ileum, especially the terminal ileum, as well as the colon. So the cause is unknown, multifactorial, but it's classified in the autoimmune types of diseases. So another big key with Crohn's disease is that the inflammation is transmural, which means, there are 4 layers. We talked about the 4 layers of the GI tract. And in Crohn's, that inflammation goes all the way through the wall of the GI tract. So, like pretty much all the autoimmune diseases, flares and remissions are pretty characteristic. So pathophysiology, basically you have this inflammation of the bowel wall, and you will have lymphatic obstruction and reactive lymphadenopathy. So you'll have inflammation of these lymph nodes, they're called mesenteric lymph nodes, along with this lymphatic obstruction. And with that lymphatic obstruction, you have edema, and that edema decreases blood flow to the wall of the GI tract, which causes ulceration. You can also have complications with abscesses and fistulas. You can have an abscess that ruptures or a fistula that ruptures, and you can have peritonitis, which is certainly deadly if it's not treated. So again, with flares and remissions, you have this chronic damage, this chronic laying down of scar tissue. And what happens is, as more and more scar tissue is laid down, you have more and more stenosis of the area. And this is why a lot of Crohn's patients have to get surgery, because there's so much stenosis that the contents can't get through. So clinical manifestations: abdominal pain, diarrhea, or constipation. Diarrhea is more common, but constipation does occur. May or may not have blood. Nausea, vomiting, weight loss, fever, loss of appetite. All of those are pretty characteristic of Crohn's disease. And a lot of people will still have a number of these manifestations even when they're in remission. So diagnosis, history, exam, imaging, definitely going to do a colonoscopy or an upper endoscopy. Always take a biopsy. You're going to look for blood in the feces and also fecal calprotectin tests. So calprotectin is a inflammatory marker, and basically what it does in the body is it kind of attracts white blood cells, like neutrophils, to an area. Okay, so treatment, corticosteroids, really, really common. So things like prednisone, budesonide, the aminosalicylates. So these are things like sulfasalazine, antidiarrheals, the biologics like Humira, that's the big one. Immunosuppressants, there's a whole, list of immunosuppressants that are used. And avoidance, lifestyle changes to help avoid any triggers, and of course nutritional therapy because of the lack of absorption, and surgery is quite common. Another thing that kind of differentiates Crohn's disease from ulcerative colitis is that you can have skip lesions. Okay, well, first off, you often get this cobblestone appearance. They look like cobblestones. But you can also have skip lesions, which means you can have an area of the GI tract that is completely normal. And then you have an area that is diseased. Then if you go a little further, it might be normal. So these lesions are not continuous. Okay, so you can have a spot in the ileum, you can have a spot in the jejunum. Okay, that's going to be different than ulcerative colitis. Now here you can see abscess formation, another little abscess. You could have a fistula, which is just a connection between two tubular parts of the body. Lots of possibilities. Now, ulcerative colitis, this is the other type of inflammatory bowel disease, but it only affects the colon, the large intestine, and the inflammation is really only in the mucosa and submucosa, so the first two layers. Okay, causes unknown, of course, and just like Crohn's, patients have flares and remissions. So here, typically the lesions will start in the rectum, and they will kind of spread through the rest of the colon, and it will be continuous. The lesions here are continuous. Okay, so you're going to have edema, bleeding's pretty common, and also abscesses can form. Now, clinical manifestations, pretty much the same as Crohn's. You see diarrhea a lot here. Typically more blood with ulcerative colitis than with Crohn's, but again, it can occur in both. But really all the same clinical manifestations. Diagnosis is really the same. Treatment is the same. The only difference is ulcerative colitis can kind of be cured. I mean, you can remove the whole large intestine, and the ulcerative colitis won't come back. But that's a big decision, and for some people, it's the only decision. So here you can see that these lesions are not quite as gnarly as the ones that you saw with Crohn's. They're more superficial, but they're continuous. Okay, so if you won't find a spot in between this and another place. It's continuous. So it's not like you have disease colon and then healthy colon then disease colon. They're continuous lesions. Okay, now let's go ahead and just talk about these burn notes really, really quickly. All right. So burns can be due to heat, usually at least 113 degrees Fahrenheit, but also you can have electrical burns, you can have radiation burns, you can have chemical burns, and basically burns are going to trigger an acute inflammatory response. So let's talk about first-degree burns, which are known as superficial partial thickness burns, and they only damage the epidermis, so the very top layer of the skin. Remember, there are two layers of the skin. There's the epidermis and the dermis. The area below the dermis is called the hypodermis, but it is not a part of the skin. All right, so you just have the epidermis and the dermis. The epidermis has 4 layers in most spots, but also 5 layers. The dermis, this is where we find blood vessels and things like that. So basically, these first-degree burns, you have vasodilations of the blood vessels in the dermis because of the inflammation in the epidermis, which gives you that redness and also some edema. Typically, people heal without any sort of problem, usually in a week. And again, these are things like sunburns, your typical sunburns. Now, second-degree burns, these are called deep partial thickness burns, and that's because they go all the way through the epidermis and into the dermis. All right. So if you have a very severe sunburn, that can cause a deep partial thickness burn. Also, if you are scalded with really hot liquids, and some of these chemical burns can cause this. One of the hallmarks of second-degree burns or deep partial thickness burns are blisters. Okay, and these blisters form from exudate that basically will split the dermis and the epidermis. So if this is the dermis, what happens, and this will be the epidermis, just this thin layer here. What happens is when you have this inflammatory response, mostly from the blood vessels down here in the dermis, you have this separation from the fluid that gets between the epidermis and the dermis. Okay. So you can have scarring definitely here because, these cells can be damaged to the point where they die and are replaced with scar tissue. You have lots and lots of fibroblasts kind of hanging around here, so they can come in and just kind of, lay down lots of collagen and elastic fibers. Not so much elastic fibers, mostly collagen. And healing typically occurs in 2 to 4 weeks. Now, full thickness burns, these are third-degree burns, and these go all the way through the epidermis, all the way through the dermis and can extend down into the subcutaneous tissue. So not just the hypodermis, but also muscle and bone. Okay, so prolonged fire burns, very, very hot liquids or objects, definitely electrical burns, some chemical burns can all cause these full thickness type burns. Blood vessels are destroyed, and that's just because the heat basically cauterizes the blood vessels. All of those skin cells are died, or all those skin cells die, and you also, basically burn away these important skin proteins like elastin, which gives your skin elasticity, and basically you will have just scar tissue that's laid down, and mostly just collagen. Collagen's pretty stiff protein, so that's where you get the scarring. And you can also see contracture, which is basically, for example, if this is an arm, okay, here's our hand. That's a beautiful arm and hand. Look at that. Well, basically, say you have, a burn here. What can happen when that scar tissue forms is this is called a contracture, where basically you get stuck in a position, or you lose mobility due to not really the tightening of the skin, but the laying down of the scar tissue. You lose the elasticity in the skin, and it can cause these contractures. Now, if burns cover more than 20% of the body, you can have real serious issues. So infection occurs. So things like Pseudomonas just loves burn wounds, but also you lose plasma proteins, which can cause fluid shifts and edema. Your ability to regulate your temperature is impaired because you've lost so much of the skin, which we know is important for thermoregulation. Also malnutrition. Just a big problem. We all know how serious burns can be, especially third-degree burns. So I just want to go through those. Just be familiar with these notes. I'm just going to have a couple of questions. They're going to be, really, really just, straightforward questions off these notes. And as always, if you have any questions, please let me know.